Hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, along with my producer, Lindsay, in wonderful downtown Boise, Idaho today. And on our call today, we have Dr. Kelsey Smith, all the way in Oklahoma. I'm looking out the window right now, and I'm looking at fog and 30 degrees, and I'm guessing that Dr. Kelsey Smith has some warmer weather. So
Not actually.
Yeah, right? Oh, really? Interesting. Okay. So you don't want to miss this episode because Dr. Kelsey Smith is soon to be opening a DPC clinic. You guys that follow our podcast know about DPC, direct primary care. She's tired of the insurance model, and she realizes that she can help patients better and be more affordable if she opens her own clinic and doesn't take insurance. So one of the stories that I really like about this is that she has a great story about how there's a patient that actually qualified for Medicaid, which if you guys don't know, that's state-funded medical insurance. And this patient doesn't want to qualify for Medicaid. She wants to pay Dr. Kelsey cash in order to seek care and have good access. So some of the times I get questions all the time. It's like, well, I went into healthcare to help people, not just to help people that can only pay cash. Let me tell you something. Insurance coverage doesn't mean care. Coverage doesn't equal care. So just because somebody has government insurance, whether it be Medicare or whether it be Medicaid, does not mean they get access to a doctor. So that's why Dr. Kelsey Smith is changing her model, because she wants to be have patients have good access to her. So stay tuned for the entire show to find out how she is going to do that. So she is opening up Pioneer Health DPC in Stillwater, Oklahoma in January, I believe, which is just a few weeks away. So Dr. Smith, tell us about your journey.
Yeah, like you said, I'm in Stillwater, Oklahoma. I'm a small town Oklahoma girl at heart, and I'm a small town doctor. Stillwater is a town of about 50,000, but we service a very rural area extending up to the Kansas border and into the Oklahoma Panhandle. So a lot of my patients are hardworking folks that are in agriculture, but also industry and education. We're in a college town, so I have a very diverse patient population. When I went into medicine, I didn't think I would do family medicine at all. I really thought I'd do something along the lines of anesthesia or something that I could kind of hide from the patients that I was serving and not really know their names or know their story, but practice my trade. And throughout medical school, that's one of the first things that I learned along the way, was that I really kind of treasured those interactions with patients, and I liked all aspects of medicine. I like the pediatrics rotation. I like obstetrics. I like surgery. And family medicine was something that offered a chance to continue all of that, rather than to just say goodbye to a whole segment of my patient population that I'd been taught to treat. And what was interesting to me was, when you start to consider a career in primary care, you get a lot of criticism as a physician, because primary care is considered kind of a fallback plan for a lot of medical students. It's one of those things that we know primary care physicians don't make as much money. We can't pay back our student loans as quickly as some of our specialist colleagues. And it's oftentimes what you do when you have nothing else you can do. That wonderful plan to join an orthopedics residency fell through. And so what's your backup plan? Maybe you'll do family medicine. I'm proud to say that family medicine was never a backup plan for me. It was something that I wanted to be able to practice all of the tools that I was taught. And so that was the first kind of revelation, that family medicine was something that you could help people through a relationship with them, rather than prescribing medications or providing a procedure per se. That therapeutic relationship was what was really valuable. Interestingly, we both know that insurance places zero value on relationship-based care. So that was one flawed part of my plan, but I pursued family medicine to be able to provide that therapeutic relationship, care for entire families. I did an obstetrics fellowship after my family medicine residency, and have provided obstetric care here in Stillwater for the last 13 years, along with general family medicine. So true womb to the tomb type of care. We do our own hospital rounds, and we kind of do it all. But that was probably the second thing that kind of was a wake up call to me in medicine was when I did finish my training. In 2007, I graduated from the OU Family Medicine program in Tulsa, and was like any young resident looking for places to work. And even 13 years ago, the primary means to do that were to sign a contract with a hospital system as an employed physician. And none of those employment contracts really seemed all that great. They seemed to kind of hem you in and try to buttonhole you into what you were going to do and for how many hours a week and for what type of patient population, and really didn't give the doctor any control. But I didn't think there was really any other option until I was approached by one of my current partners here in Stillwater, who had already started an old-fashioned private practice clinic, and said, there is still a way to practice medicine as a private business. And there's a reason all these people are offering you contracts. They look to make money off of us. And so that was my second wake up call, was to join private practice instead of be employed. And so in that way, I feel like I've been a little bit of a rebel, or have rebelled against the system a bit from the get go. Out of training was to just buck the system and say that that's not employed relationship is kind of a conflict of interest between my patients and myself. What I didn't realize was I was still in a conflict of interest, not just, even though I was free of the employment constraints, I was still hemmed in by those insurance contracts that then I was forced to be a part of. So when, I started 13 years ago, you want to be on as many insurance contracts as possible because you're looking for patients. And so in the last 13 years, I've been a part of, Blue Cross, United, Cigna, Aetna, Health Choice, all of the big names, plus all the government programs, Medicare, Medicaid, all of those types of things. And they've all gotten increasingly complex and cumbersome over the last 13 years. And with a lot of the governmental programs that have started, it has been a bit of a wake-up call to realize that they never intended to design the game to be won by individual physicians, and certainly not for patients either. So realizing that insurance really doesn't have my best interest or my patient's best interest at heart, I started thinking outside the box. Direct primary care had been something on my radar since about the time MIPS and macro were introduced in the Medicare landscape in about 2015. And we started looking at how we were going to deal with those increasing requirements by the government. And at that point, we ended up joining an ACO as a group rather than proceed with, jumping into the direct primary care landscape. But even that's becoming more and more complex. And direct primary care is a way I can, kind of jump out of that fire and provide real care for my patients.
For myself, and maybe our listeners and viewers too, what's MIPS and macro? And I know if it's a government program, it has to be complicated. Give us the Reader's Digest version.
It's a Medicare program designed to be a payment-based model based on quality. But as we know, the government and insurance can't really define quality because they're not there within the relationship with the doctor and the patient, because the quality of healthcare is defined by what the patient's goals are, not by a particular number that can be generated by an electronic medical system.
Right. And then explain to us what an ACO is.
An accountable care organization. So you can join together with other clinics or hospital groups to basically absorb risk as a group rather than take that risk upon yourself as a clinic. So you're saying, okay, well, as a group, we are going to try to meet these quality goals rather than as an individual clinic. So at the end of the day, rather than pay you for good care, the idea is at the end of the program, if you haven't met the bar, you may be required to pay money back into the system that has already been given to you. So if you don't meet their predefined standards of care, you have to then remit payment back to the government. And so through the Affordable or Accountable Care Organization, that helps to limit each individual party's risk by pooling that risk into a larger group.
I see. Okay. Thank you for that education piece, because I had no idea. There's so many, anytime the government creates something and it has 3 initials, it's really complicated, and that the only winner is going to be the government. And it's going to be really expensive to try to follow those models. Speaking of expensive, EMR, another 3 initials, which is government mandated since I can't remember the year. If you want to build our government programs,
Right.
you were before the show, you were talking about EMR expenses. So can you go ahead and hit on that a little bit, and how these electronic medical records, when the doctor has their computer in your face, when you're seeing a patient, they're checking the boxes, has nothing to do with quality? Or is that correct?
Not quality as a patient would define it. We are clicking those boxes to try and meet the quality measures that are predefined by the third-party payers, but that really has nothing to do with what the patient would define as quality. So, clicking through to say whether this person is at an increased fall risk, whether they need to discuss tobacco cessation, or whether they're at risk for depression, all these things that they want to have checked at every visit. It doesn't matter why they were there. If they're there for a sore throat or high blood pressure, all these things have to be checked. So those are part of the things we're doing with the electronic health record. I guess, I date myself by saying when I graduated from medical school in 2003 from the University of Oklahoma, we were just starting to debut these electronic medical records at that point. And I guess I had a little bit of optimistic view of what these systems could provide, because, paper charts are cumbersome. They can get lost, and they're not portable, and you can't share them easily amongst healthcare teams. And so an electronic record seemed like a great idea. The interesting thing about it was it became a tool for the bean counters rather than for the medical professionals or the patients, either one. And so you have to be able to code things into computer speak for the bean counters to be able to look at their endpoints. How many people have reached their ideal blood pressure for hypertensive patients? How many people have reached a goal A1C that are diabetics? The idea then becomes that you're a better doctor if you've clicked the appropriate boxes, regardless of what you've done for your patient. And those medical records have gotten increasingly cumbersome and complex, and mainly to create a document that is either searchable for those quality measures or can create a complex billing document. ICD-10 was another landmark in the last few years that got rolled out that provides an increasingly complex structure for diagnosis of patient conditions that then can be linked to a payment code on the back end. And so the electronic medical record is now really a very complex billing structure rather than a tool for doctors and patients. And so I've used the same electronic health record since 2007. Well, actually since 2003, because my residency program used this same record as well. As a product put out by GE called Tricities. But that is an obsolete program now. And so it has gotten bought by one of the healthcare giants in the electronic medical record world called Athena. And the idea is they're not going to provide service to a product that they have purchased. So they were kind enough to offer us an upgrade to their brand newest version of Athena, which of course has all the bells and whistles to provide you billing features and make sure everything with insurance is submitted clean and you get your payments back as quickly as possible. Still going to be a 60-day turnaround or something, but yeah, they promise that that's part of what they can offer for the low price for our 5-physician clinic of $332,000. And that was not something that was feasible for us. And it's things that, and even the people I have as patients who are also my friends don't realize goes on behind the scenes in trying to run a medical practice for really every patient we see. And as costs go up, you have a few different options. One is to sell your clinic, which a lot of physicians have. That's why you can't find very many private practice physicians out there anymore. They've just opted, say the business of medicine is too complex. I can't keep up. There's too many regulations and too many bars to meet, and the rules are different according to which payer you're trying to please. And so better to just sell out to that health system that is all too eager to buy your clinic. And that's one option. The other is to just run faster on the hamster wheel. And truthfully, that's what we've actually tried doing for the last several years. Every time we're faced with a new requirement, well, then I guess we need to fit 2 more patients into our day, to try to make ends meet and try to meet those requirements that the government and third-party payers are passing down to us. But that obviously doesn't work either. Pretty soon you wear out your hamsters. So I guess that's one reason. Another reason that I started looking into the direct primary care option.
Well, I'm glad you are, and I'm glad you decided to make the switch, because it's a sad reality that many good doctors like yourself, they basically have 2 options. They either leave medicine, or they start a practice like you're talking about in DPC. Unfortunately, a lot of them have left medicine because it's just such a racket. And when I think about that $330,000 for an EMR, as is typical with any kind of government program, because that's a government program, the EMRs had to, they in order to bill Medicaid, Medicare, to do the government programs, you had to have an electronic medical record that was approved by the government. So if you follow the dollars, Athena, that big group, they have spent millions of dollars on lobbying the government to make it mandatory that you have to have an EMR, and it doesn't make patients any safer whatsoever. And all it does is it makes the insurance in general, all it does is make things more expensive. It doesn't, quality of care. It does not give anything with quality. Just because you have insurance doesn't mean you get care. In fact, I will say this. I think health insurance most of the time is a barrier to care.
Absolutely.
Yeah. You want to expand on that?
There was a case not long ago that someone came in with back pain that had been conservatively managed for quite some time, but he continued to have symptoms that made it appear he probably had a disc that was needing to be addressed, potentially with a steroid injection into the epidural space. But to localize that, an MRI was going to be necessary. So he was in enough pain that his pain, I think, is what probably prompted his I guess the need, the need to look for other solutions to our problem, because to get that MRI scheduled through his insurance was going to require a prior authorization and potentially a week or 2 before that could be scheduled. And then, how much is that going to cost? I don't know. Have you met your deductible? And it's right. About $2,500 to $3,000 out of your pocket. If you've not, if you have, then depends on what your contract says. Is it an 80-20 type of thing? Or, so I have no idea how much that MRI is going to cost him in the end when it goes through the insurance system. And he just asked me, is there any other way? I would like to get this done today if possible, And so we are fortunate that we have some private imaging companies that are nearby, and they have branches across the state. And they were not able to do an MRI here locally, but just about an hour away in Edmond, Oklahoma, they were able to schedule an MRI. I asked them what the cash price was. It'd be $300. And so he went down, had an MRI of his back that day. And we got the information we needed so that then he could be referred to a pain management physician who could then do that epidural steroid injection.
And with the insurance, if he ever got an MRI, it would have been weeks later. Mm-hmm. And I guarantee you, even with his insurance coverage, even if he had met his deductible, he is going to pay more than $300 out of pocket.
Oh, easily.
Guaranteed.
Guaranteed. But that's part of the racket, as you say, is that you see these inflated prices that were never really meant to be based in reality as far as the expense that it takes to provide that service. And it reinforces the belief that you have to have this very expensive policy to cover your healthcare expenses, because how are you ever going to afford these types of things when they come up if you don't have this plan to protect you, per se, when really, all of us in direct primary care are now having the courage to say that the emperor has no clothes. That's just not true. There is a way to make healthcare more affordable.
Well, yeah, and the way is what you're doing is actually, get out of insurance. I mean, people think that in health, and I think we've been indoctrinated by the government and by the media that everybody needs to be insured, and that's what you need. You need to be insured, and that's what's going to make healthcare cheaper. Well, the reality, that's what made healthcare expensive. Right. Let's face it. You follow the history of it, and what really made it expensive, and when it just started going off the chart, is when Medicare back in the 1960s became law. And before that, there's stories of doctors I was delivered by a doctor that started practicing in the 1960s, and he would do, I think he would do home visits for $3 and office visits for $1, and follow-up call. Those were new patients, and follow-up calls for $1. Now, fast forward, 50 years later, a little over 50 years later, and an average office call is probably $300. Mm-hmm. Don't tell me that inflation went up that much. Right. It's due to the federal government being involved in it and creating just a mess. And speaking of that, so I wanted to mention that my book is available in paperback. I just recently released a paperback book, and it's called Sickened: How the Government Ruined Healthcare and How to Fix It. And it goes into the entire history in healthcare of how the government actually created this mess. There's a 6-step solution. Last year, it was a #1 seller on Kindle version. We released a paperback version just yesterday, and it's being promoted heavily on Amazon, and it is a best-selling preventive medicine category Kindle version. It is a #1 new release in the pharmacies category and paperback version. Yesterday was a special deal, but it's still not too late to get a deal today. So go to Amazon today and download or order my paperback version book, Sickened: How the Government Ruined Healthcare and How to Fix It. Because one of the things is that doctors like Dr. Kelsey Smith, we talk about DPC in the book. They are a part of the fix of the problem. The way to fix the problem is not fix the system, but to get out of the system, because the system is a scam. It's a ripoff. And that's one of the goals of this podcast, is to educate and empower consumers that you guys are in charge of your own health. And that means the government shouldn't be, your health insurance company shouldn't be, your employer shouldn't be. You should be in charge of your own health, and that includes financial too. You can make those decisions, and healthcare can be very affordable, just like Dr. Smith is talking about. Speaking of affordability, Dr. Smith, how affordable is direct primary care? When you open up in January, how affordable are you going to be?
The interesting thing about that is, when the people ask me why is it more affordable? I'm providing the same services. So how do the prices come down? And the reason is we have in-office people who basically work to make sure we're going to get paid through that insurance system. They double check our billing charges, double check the charts to make sure all those boxes are checked that make it a better, clean claim to go to insurances and help to ensure that you'll get paid. So we have several office staff that do that. We then also contract with a billing company out of Tulsa, Oklahoma, that submits those claims for us, and of course takes a percentage of our collections after we receive those claims. And then of course there's always going to be a percentage, and sometimes a surprisingly large percentage of claims that have to be reworked to try and obtain that payment. And that's why people end up getting a bill, after a simple office visit, maybe 2 or 3 months later, that truthfully, they don't remember why they came to the doctor that day. I probably don't remember either, unless I look back at their health record. And so that's, there's a lot of time spent where I'm trying to pay my staff and keep the lights on, where payment has not occurred for a service for 2 or 3 months, and continuing to pay the billing system to make this happen. So when you cut a lot of that out, then it does. Direct primary care is a perfect name for the system, because a patient is just contracting with me. It cuts all those middlemen out that, of course, are all drawing a salary. And unfortunately, in the direct primary care method, and hopefully, fortunately, those people are free to go find another source of employment because they're not needed anymore. So excuse me.
Yeah, but that's part of the problem.
It is.
I mean, think about it. If you do what you're doing, I've heard, and please remember your train of thought. I've heard that the average doctor's office now, this is a few years ago, the average doctor's office now has 9 people that support them. Most of those are due to insurance billing. Think about that. When you go to your office, I'm going to guess your new office with direct primary care, it's going to be you and maybe a part-time, full-time receptionist type person, maybe a nurse type person. So basically you got rid of 7 or 8 people. And that's a problem. So they want to perpetuate the system. Those people that are employed, that's why hospitals are traditionally inefficient. Those people want to stay employed, you know, and even though they deep down inside, they know the scam, they know it's a ripoff, but they want to keep their job. So anyway, that's part of the problem. So go ahead and keep going with where you're going.
So starting off, my adult patient price will be $85 a month for all-inclusive care, anyone from 18 to 65. If they add a child onto that, it'll be an additional $25 per child for that care. Doesn't matter if they come in 5 times a month or if they don't need me that month. I'm available for whatever they might need. The other side of that coin with direct primary care is I'm leaving the billing system type of electronic medical record behind for a more functional electronic medical record that is focused more on the relationship. So the communication that has to occur between doctor and patient. So part of what I think patients want to pay for when they have a physician is access, like you said, access to that care. And so even now, when I see somebody the same day that they call, that whole process is going to require that they call my front office staff. My front office staff takes a message and they might send that message to my medical assistant or potentially straight to me. Looks like your schedule is full, Dr. Smith. Can you fit this person in? And I say, well, yeah, how about 1:15? Let's put them, next to something else that looks to be pretty quick. And then that message gets sent back to the front office staff who then calls the patient back. And they may be doing something important. So then they leave a message and then that person has to call back. So you see how convoluted a simple same-day appointment can become. And in the direct primary care model, the software is designed to simplify that whole process to where every person who enrolls in the direct primary care model has a phone number they can text or email, and that comes straight to myself and my medical assistant. So then that can be directly answered by text or email. And oftentimes the situation can be taken care of without an appointment. Because that's one thing that the insurance model has perpetuated as well. That's the only way a business transaction takes place is if there is an actual appointment with the doctor. And prior to our pandemic, we found ourselves in that had to be an in-person appointment. Telehealth did not count. And so we've been able to incorporate telehealth since COVID-19, but that will soon come to an end, I'm sure, because insurance wants, if telehealth occurs, to be with their chosen telehealth provider, not your primary care physician that you know and trust. So the new system will then allow people to communicate with us more efficiently and more directly, and hopefully facilitate care that may not require an office visit to accomplish the means that we hope to accomplish.
Yeah. And, I will say for the doctors that, we work through Moses Lake Professional Pharmacy. We have a network of a lot of DPC doctors that we work with. And I will tell you, one of the coolest things is when you meet these doctors and you go to their clinics is usually they're the ones that are up front many times. Or if not, they have a receptionist up front and, you'll see the doctor come in and say, "Hey, Mrs. Jones, you ready for your appointment?" And the doctor's like, and patients are just like, "I can't believe the doctor came out and actually asked me to come back. He checked me in." Well, yeah, I mean, why not? And it's such a convoluted system that we've created in a traditional model, and it doesn't have to be that way. And I tell you, I feel for doctors because they are strapped. And, I think the average doctor actually gets to see, you could probably know these numbers, Dr. Smith, but 5 to 7 minutes with a patient. Does that sound about right on average?
Yeah, it is. On our current scheduling system, it's set up for a 15-minute basic appointment for, basically any type of appointment, maybe obstetric, pediatric, geriatric. 15 minutes is allotted for pretty much any basic appointment. And that can be stretched to 30 minutes, but then a lot of times you might end up squeezing somebody else into a 7.5-minute visit so that you're not losing revenue on that. So that's what we find in our current system is 15 minutes allotted per patient, but which sounds reasonable until you realize that half of that time or more than half of that time is spent documenting what happens in that time frame. So that's why patients don't see the entire 15 minutes with their physician is they're stuck creating that billing document that the electronic health record requires, either while you're talking to your physician, and that's why they're not looking you in the eye and seemingly paying as much attention to you as you would like them to be, because they're trying to multitask and create this cumbersome document at the same time you're speaking to them, or they spend half the allotted time with you and then finish their documentation afterwards. Unfortunately, I guess this is another reason I fit better in the direct primary care world is I would tend to spend the 15 minutes or more with the patient that was scheduled and not get the documentation done, and then move on to the next patient a little bit later than they're scheduled and not get their documentation done. So then at the end of the day, I'm left with these multiple charts to complete and check the boxes to either stay late to complete or take home with me. And in fact, my 12-year-old asked me the other night, he said, "Mom, once you're in direct primary care, are you going to have to stay up late at night charting?" And I said, "Well, I sure hope not." That's part of the reason for the switch is to try to get away from that broken system.
Absolutely. And that's what really needs to happen, because doctor burnout is a really big issue. And, I don't think as patients in the system, they really want a doctor that's burnt out taking care of them. Right. Unfortunately, that's kind of the norm now. So kudos to you. So I do have so obviously $85 plus $25 for a kid, very affordable. It's less than a cell phone bill a month. Mm-hmm. And, so tell us, commonly when I talk to people about this, even people that are in healthcare, even doctors that are in healthcare. And I will tell you, I think there's a lot of doctors that are stuck in the system, and by their own fault, honestly, because they're fearful, and I get that, but they need to step up and step out of the system so they're not accessories to the crime. I'm quoting Dr. Keith Smith about that because he has said that over and over again. Dr. Keith Smith, we've talked about him a lot on this podcast. He's the co-founder of the Surgery Center of Oklahoma and the anesthesiologist himself. And he felt when he was in that insurance model that he was an accessory to the crime. So, he has a great model in Oklahoma, cash transparent pricing of, complete surgeries with all inclusive. And, he's one of the quotes on my book. He quoted on the cover of my book, he quoted about being an accessory to the crime, and that's why he got out. And one of the things I try to do when I talk to other healthcare providers is I used to defend them. And I used to say, yeah, I get it. You're in pharmacy, or you're a nurse, or you're a doctor. And I get it. You're stuck in a big hospital system. I used to say, but it is what it is. You just have to, keep going through the grind. I don't agree with that anymore. After talking to Dr. Smith, I think we all need to stand up and get out, because we're being an accessory to the crime and just perpetuating the situation when we stay in it. So you're making healthcare affordable. Obviously, you just gave us some prices that make it affordable. So, but unfortunately, when I talk to some of my doctor friends, their first definition is, the first thing they'll think of is concierge care. And I don't want to turn away Medicaid patients. And, sure. I don't want to just help rich people because it's just for rich people that can pay cash. You recently have a story of a patient that you are currently following, and her health insurance costs went way up, and she was going to have to qualify for Medicaid. She's excited for you to be a DPC doctor because she's going to be able to afford to go to you. Can you explain that a little bit, that story?
Yeah, I mean, we've already created a dichotomy in healthcare where to have private insurance becomes so unrealistically expensive, even if your employer is paying a portion of that, which if they are, that's wonderful, but you don't realize how much of your paycheck is right. You're leaving on the table because they're paying for your health care. In her case, her employer was able to provide her healthcare insurance. So when it was just her, it was $40 a month for her healthcare insurance that she paid, out of her pocket. Now, her employer was obviously paying a much larger price for that, but she didn't see that out of her paycheck. She didn't pay it back. When she got pregnant, her prenatal care was going to cost an additional amount out of pocket for her. And I was her prenatal provider. And when she spoke with her benefits provider at her employer, they said, well, that's just how this plan is written. Yes, you will have quite a bit out of pocket, but the nice thing is you qualify for state Medicaid that will then be a secondary insurance for your obstetric care, and you won't have to pay anything out of pocket. So, she's a realist, but also a very proud person who says, I don't really feel like I need a handout to obtain my medical care, but I guess if that's the way the system works, okay, I'll sign up for state Medicaid. So to save the dollars and cents, she now has the private healthcare insurance that's supposed to take care of the job, but it doesn't. So then she gets state Medicaid as a secondary to help to cover the cost of that delivery and hospital stay and all of that entails. Her child is born and she goes back to her employer and says, I need to add my new baby to my insurance plan. And they say, oh, that's great. Let's add her. And that'll now be $1,300 a month out of your paycheck because that, complete expense for that covered life was coming out of her paycheck now rather than the employer covering part of the child's healthcare insurance. When she protested and said that sounded exorbitant, they said, well, but no, that's okay because your child will still qualify for that state Medicaid program. And so you can have coverage and it's nothing out of your pocket. So the two options she's left with is either to pay $1,300 a month to have private insurance that she feels as a responsible citizen she should do to, not be a drain on the system and absorb taxpayer programs that are paid for by the state, or apply for state assistance when she feels like she shouldn't have to. There should be something in between that's not $1,300 a month, but it's not zero either. And so she was very excited to hear about direct primary care because it was a way that honors that person's integrity and gives them a responsible way to provide care for their family without feeling like they are taking advantage of the system. What I've found is, I take care of a lot of people who are on our state Medicaid system. They aren't looking for a handout. They're looking for a realistic way to make ends meet and to get the care that they need. And the system has forced them into that option because private insurance is just not an affordable option in most cases. People stay in jobs that they hate just because they have the benefits that it provides. And that's not how healthcare should be. Nope. So that's what's exciting about direct primary care to me is it gives people an inside look to what the healthcare costs actually are. And hopefully if enough of us do it, it will kind of bring down the veil of these healthcare prices nationwide and force the system to change.
Well, it is. I mean, it's a growing movement. It's a revolution. Thank you for being part of it. It is changing. Do I think the other system will change? Not before it implodes, because hospitals in collusion with the government, in collusion with insurance companies, in collusion with big pharma, that's not going to change. They're making billions. They don't care about patients. They don't care about doctors. And that's why when you talk of private insurance, and I talk about this in my book, in my opinion, any kind of traditional health insurance, it's government insurance, because it is so regulated by the federal government, what to pay, how to pay, what the diagnosis can be to pay, what the allowable is. All those things are regulated by the federal government. So private insurance people that your employer is paying, it's government insurance, period, in my opinion. I think the best thing to do, and I talk about this in my book, is partner with a doctor like yourself, be a DPC, and get out of health insurance, period. And the great thing is they're what's called health sharing programs. Some of them are faith-based, some of them aren't faith-based now, and they are a wonderful way to provide some kind of, it's not insurance, but they are a wonderful way to pay medical bills if there is kind of catastrophe going on. I will tell you, my wife and I, Christian Healthcare Ministries, we, up until recently, we paid $135 a month. Now we pay like $246, still very inexpensive. We save $15,000 a year over traditional insurance. And guess what? We get to decide what doctor we see. We get to decide the hospital we go to. We get to decide what's covered, what's not covered. We don't want maternity coverage. We're beyond having kids. Why should I have to pay for maternity coverage? In Washington State, if you have insurance, you've got to pay for maternity coverage. I'm a 50-year-old man. My wife's 53. I hope I didn't mess that up. She's watching probably. I know she was born in 67. Do the math. Yeah, 53. Anyway, yeah, we didn't need maternity coverage, but we still have to pay for it. And maternity coverage is expensive. So people, here's another thing. Dr. Smith hit on it. How many people, I talk about this in my book, how many people stay in a job they absolutely hate. They hate it and they feel like a slave to it. But my employer pays for my health insurance and I need that. Don't buy it. Don't buy it. Health sharing ministry can be very affordable. You do not need that health insurance. It's a ripoff. It's a scam. Most things aren't covered anyway. Do not be in slavery for the rest of your life to a job you hate because of health insurance. It's a ripoff. And I think that's one of the things, that's one of my goals, and I talk about it in my book, is that employees need to start talking with their employer and saying, you know what, that health insurance you provide me, I realize it's a ripoff now. First of all, I'm proactive in my own health. I'm in good health and in general. The best health insurance we can have. I quote this in my book in chapter 6. I quote it. It's my quote. The best health insurance we can have is not some policy that we can buy. It's how we take care of ourselves. Period. That's the best health insurance we can have, not some policy we can buy. So do not be a slave to an employer, to a job you hate because of health insurance. You can do something better. DPC, health sharing programs, they are very, very affordable. Be liberated. It is very liberating feeling, let me tell you. Dr. Smith, that's awesome. So I got some more questions for you, okay?
Sure.
Are you still going to do OB when you go direct primary care?
I don't know. That's something I'm not sure how many people will be interested in. There are doctors in the direct primary care space that are. Dr. Amber Beckenauer in Nebraska offers that, and I've had some discussions with her about how that's modeled. So it will be interesting. I'll have to have those discussions directly with the patients that might be interested, because right now, the majority of my deliveries are with the state Medicaid program. And so no longer being a part of that will be interesting. Because right now, when people are covered with that, there is no out-of-pocket cost necessarily for their delivery. And so trying to discuss any type of value for a cash-based service may be a little bit a foreign concept. The people who do have private insurance, I mean, we outline that for them when they're here for their prenatal coverage, to say, well, this is what your out-of-pocket will be. And oftentimes, their out-of-pocket cost for their prenatal care with me, I can't say their delivery because there's hospital charges on top of that as well. But my portion of their care, even through insurance, may be $1,500 to $2,000. Through their insurance model. Now, that's the exact same price I could offer them for my services cash. So there may be a segment that is interested in that, and that's something I'll just have to explore to see how many people are actually interested.
Yeah, awesome. Well, yeah, that's one of the questions we always get, and that's why I like the DPC movement, because there's more DPC doctors, the primary care doctors get into this. There's more specialists like orthopedic surgeons, like urologists that are kind of gravitating towards it, because then they have kind of a place to refer people to. And there might be DPC doctors that, don't have OB privileges or don't deliver babies, but they could, refer a patient to somebody like you. So as the movement grows, that's what's going to happen. And I love it, because 5 years ago, that wasn't always the case. It was like, well, I mean, I'm kind of, you'd have a primary care doctor that was kind of stuck out there and say, well, I don't know. I mean, you need surgery for your knee or whatever, but I've got to fit into this hospital. It's going to charge you $50,000, and so Dr. Keith Smith has been a great pioneer in that area. And, and there's other surgeons that are following, and I can't wait to see more surgery centers are popping up. I want to see birthing centers pop up. I mean, I will tell you, if I was having a child today, I wouldn't go to a hospital. There's no way. You're going to be surprised with a huge bill. Service, let's face it, service sucks. Quality sucks. I mean, it is what it is. Hospitals are expensive. Their service sucks. Their quality sucks. And it just is what it is. And so I would much rather have paid cash for, if I was in that market, I'd pay cash for it to a birthing center for sure. So Dr. Kelsey Smith, thank you for being on our show. I want to ask you one final question.
Sure.
So what drives you? What fires you up? Why do you do what you do? Why do you get out of bed every day and do what you do?
It really is. I touched on it earlier. It's that relationship-based care with my patients. And that's something that is not valued in the current system. When I come to work and when I see somebody for their high blood pressure, it's rarely solely a discussion about their high blood pressure. It's a discussion of, where is your stress level right now? Why is your blood pressure high? What does your mental health look like right now? What type of family history do you have? Do we need to, be delving into that? And so getting to know my patients personally and their families is what I think makes me a more valuable physician to them, rather than knowing that their blood pressure might be 156 over 92 and what the algorithm should be to lower that. So it's not the knowledge, the medical knowledge that gets me out of bed each day to keep doing this job. It's the relationships I have with my patients to be able to point them in a direction that will lead them to better health. And so that's what I usually say when I send out my emails to my patients is I just thank you for allowing me to partner with you in your healthcare, because as you said, it's the patient's proactiveness is what plays such a role in the success of their health. And that's something that I'm happy to partner with people to do. The medical knowledge is part of it, and that's a tool in my bag, but it's the relationships that keep me coming to work.
Absolutely. I love it. Well, thank you, Dr. Smith, for being part of the revolution. You were definitely making a change in the healthcare system, and you're making a change in patients' lives, and that's what's so important. I'm sure that's why you went into medicine, as most doctors do. So instead of being stuck in a system that you really can't change, you got out of the system, and you're part of the revolution. Thank you for doing that. I appreciate it. I really do. Thank you for being on our show. It's been a wonderful show. And tune in Monday, 1 to 2 p.m. Speaking of delivering babies, we will have an OB/GYN doctor on who is going to talk about what you can do for prenatal care and to help delivery smoother and all other things OB/GYN related, including testosterone for women. So do women need testosterone? Yes, they do, just not as much as men. So tune in Monday, 1 to 2 p.m. Health Solutions with Shawn and Janet Needham, streaming live on my personal Facebook page and the Moses Lake Professional Pharmacy YouTube site. You can also catch us on the podcast forum. So Google, iTunes, SoundCloud, Stitcher, all those, iHeartRadio. Go to those, like them, share. Please like our YouTube page so you don't miss any updates. And that concludes our show today. Thank you so much again, Dr. Smith, for agreeing to be on. We want you to keep us updated on how your practice goes in January, and we would like to do a follow-up show maybe 5-6 months down the road to see how you're doing. I'd love to check in with you.
I appreciate it. That'll be wonderful.
All right. Thank you for listening to Health Solutions with Shawn and Janet Needham. Tune in Monday, 1 to 2 p.m. Thank you so much for watching and listening.